everyone, welcome back to my channel. What is our discussion all about today? Pre-eclampsia and eclampsia. What is pre-eclampsia and what is eclampsia?
Alright, so I'll start with preeclampsia because that usually leads to eclampsia in most cases. So for preeclampsia, it's a multisystemic disorder that is characterized by hypertension and proteinuria. So when we have hypertension and proteinuria, we can actually, especially proteinuria, then we can actually say yes, this is preeclampsia. So now moving on to eclampsia would be the addition of generalized tonic-clonic seizure, fits as the case may be. So that's in addition to the symptoms of preeclampsia. That's what gives eclampsia. And I think I would like to add that we need to have there's a distinction between preeclampsia and other conditions like chronic hypertension and gestational hypertension. So we need to be able to differentiate which is which. And from the definition of preeclampsia, it includes the presence of proteinuria. So if there's no proteinuria, it's highly likely it's just maybe gestational induced hypertension. That's in the presence of pregnancy, meaning it's the pregnancy that's causing the hypertension. But if there is no pregnancy, right, and the woman presents with hypertension, so we can only say it's hypertension or chronic hypertension. But if the woman was previously normotensive, that means not hypertensive before pregnancy, and then shows the symptom of hypertension from 20th week, then we can say this woman has preeclampsia. So yes, it's also part of the definition. It occurs in the second trimester, that is from 20th week, and it's expected in most cases to resolve within 6 weeks postpartum. So but if this doesn't happen, then it could just lead to other complications like that. So but that's basically what preeclampsia means.
What are the risk factors for pre-eclampsia?
Thank you.
You're welcome.
Yes, there are a whole lot of them, really. So I'll try to mention at least a few of them. And the obvious, of course, being if a woman has a previous history of preeclampsia, then of course we need to expect a reoccurrence. We also have maybe history of hypertension, of course, and history of diabetes mellitus, history of autoimmune conditions like SLE, that's systemic lupus erythematosus. We also have even low socioeconomic status as well, because if people don't have that means to gain access to quality healthcare, health checks per time, then of course it leads to this condition like preeclampsia. Then we also have women who are advanced in age, as it is written in some books, like extremes of age is a risk factor, maybe too young or too old. Then in particular, if someone is for example at age 40 and above, having her first child, then that's really a risk for preeclampsia. Then it's also, I saw somewhere where it was written that daughters of women who have previous history of preeclampsia are 4 times at risk, of having the same condition during their time. So yes, these are some of the many risk factors of preeclampsia.
What are the clinical features of preeclampsia and eclampsia?
Thank you. Okay, so I'll start from the obvious, like from the definition now, the presence of hypertension and proteinuria. So that gives us 2 clinical features already. That's elevated blood pressure and the presence of protein in urine. That's also what we know as proteinuria in medical term. Then, of course, what the patient will also tell us, maybe headache, dizziness, of course, epigastric pain, pain in the, upper middle area, well, for the layman, but I mean, for the professionals, the medical professionals, you understand epigastric pain. Then, we also have nausea. Some people present with nausea and vomiting as well. So, yeah, low urinary outputs, proteinuria, as mentioned earlier. Yeah, those are like the common, clinical features. Yes, of course. Thank you. Then, of course, for eclampsia, well, I thought maybe we might just treat eclampsia maybe, later on. But if I could just add now that for eclampsia, all of these features will present, it will now include fits like convulsions, like I mentioned earlier. So that's like the addition. That is the major feature that makes us name it eclampsia. That's the distinctive feature between eclampsia and preeclampsia. Yeah.
What should you investigate when any of this is suspected?
All right. So because I think I mentioned earlier that preeclampsia is a multisystemic disorder. So multisystemic meaning that it affects so many systems, namely the cardiac system, the hepatic system, the coagulation system, So we want the renal system as well. It's worthy of note. So it also affects the brain. So we could, also include that. And looking at these systems, we now check, we are able to better know what investigations we would perform or we would need to perform for the patient. And that would be full blood count. We want to check full blood count. We want to check platelet count as well, because like I said, it affects the coagulation system. So it could lead to something like coagulation, then hepatic system, because this syndrome I'm going to mention now, HELP syndrome, it's like both. It's like under coagulation and hepatic. So HELP syndrome, that is hemolysis, elevated liver enzymes, and low platelet syndrome. So we want to check for platelet counts, we want to check for liver enzymes, so liver function test comes in. So we also want to check, when HELPs, one of the characteristic or features of HELPs would be dark urine. So that leads us to renal system. So we want to check, I'm just using HELP as an example, there's so many other complications, and complications that can arise. So I'm just using HELPs, to point us to the various investigations that can be done in general. So for the renal system, we want to check renal function test. We want to check urinalysis. We want to check, the electrolytes, urea, creatinine, uric acid, all of that we need to check. We also need to do ultrasound because we want to check the viability of the fetus, right? So while we're doing all of this, cardiotocograph and all of that to know if the fetus is in distress, if we need to do something immediately. So yes, all of these investigations are really important. Yeah.
What are the management principles for pre-eclampsia and eclampsia?
Thank you. All right, for the management principles for both, there's this protocol, as I think it applies generally, really. So that would be resuscitation first. We want to make sure, the airway, breathing, circulation, we want to make sure they're on point. That means we maintain a patent airway. We want to also make sure we give intranasal oxygen, when necessary. Then we also want to measure, the electrolyte level and make sure they're balanced as well. Then we also want to, in the case of preeclampsia, of course, we want to prevent seizure, right? And in the case of preeclampsia as well, we want to also control blood pressure. So we control blood pressure by using vasodilators like hydrolaxane. You want to use also drugs like labetalol as well. Drugs like that can help to manage, the high blood pressure. So now we don't use drugs. Talking about high blood pressure now, we don't use drugs like the ACE inhibitors, yes, because they usually cause renal failure for the fetus, especially. So we stay away from ACEs. We stay away from diuretics as well. Because the patient's already dehydrated and all that. We don't want to worsen the situation further. So we stay away from drugs like that. So of course, so the drugs, usually recommended would be adrenaline in most cases, and like drugs that are beta-lol, these alpha beta adrenergic blockers. Yeah. Then I saw somewhere also that we can have of course, in the case of seizures, that's eclampsia now. If there's a presence of fits and seizures, of course, we use anticonvulsants, like magnesium sulfate, phenytoin and all that. But I usually find the most, magnesium sulfate used. So yes, that could help with the convulsing. That's in the case of eclampsia now. Yeah. So in the case of severe preeclampsia, you just want to get the baby out, because the baby, definitely there will be fetal distress. So yeah, and something I probably forgot to mention, it's said that the cause of preeclampsia is unknown. Usually it's just said, but some textbooks also explain further and say the problem usually starts from the placenta, from a failure of trophoblastic invasion of the spiral arteries and all that. So it just, all of those, I won't want to bore you with the details, the pathophysiological details now, but it now leads to the increase of blood pressure, partially compensating for that failure. So yeah, so they say, some people say, there's no cause, but some people also speculate that this might just be the cause. So now in case of severe preeclampsia, it's like, elevated blood pressure, and the fetus also will be in distress. So that's a clear indication for delivery. Also, well, if the pregnancy is term pregnancy, then we can as well just, really deliver the baby. So, and if there is like imminent eclampsia, we can also say, okay, let's just deliver the baby to prevent, that. So yes, those are like indications for delivery. And I might like to add also that whichever form, the mode of delivery, I don't know if that was, if you were going to ask that, but anyways, let me just add that for the mode of delivery, it doesn't matter if it's vaginal delivery or CS. It's not a contraindication, in this case of preeclampsia, it's not a contraindication. You could deliver via both modes, as long as for vaginal delivery, there are no other contraindications, right? There are no other contraindications, like maybe all this cephalopelvic disproportion, for example. Those are other outside, the preeclampsia case. So if there are no other contraindications, then of course we can go on with vaginal delivery. But again, somewhere it's written that for a preterm baby, it's usually more, should I say, safe or advisable to go with lower segment cesarean section, because you don't want to put, the premature baby through further rigorous, maneuvers through the vaginal delivery. So it's like, just bring the baby out and straight to the neonatal ward, or, straight into the incubator for premature babies. Well, I wouldn't really go further, delve deeper in that for the sake of time. So by just saying, in case of magnesium sulfate toxicity, because you want to monitor, how you administer the magnesium sulfate. So in case of toxicity, you see a major clinical feature being loss of knee-jerk reflex. So once you notice that means maybe you might be giving too much being within 3.5 to 5 millimoles per liter serum magnesium sulfate. That's when you check. So you'd feel that, that means you're giving too much. And you might want to just give calcium gluconate. That is 10 mils of 10% calcium gluconate, slowly IV over 10 minutes. So to tackle that's in case of magnesium sulfate toxicity. It presents with loss of knee-jerk reflex, like I rightly mentioned, and also slurred speech, and you want to check the respiratory rate as well. So yes, we need to take note of that. Yeah. Thank you. Then what else for eclampsia, if I can still remember? Yeah, I think I've touched on the major. I mean, we could go deeper, but for the sake of time, but I think I've tried to just touch on the areas that needs to be touched on. Yeah. Thank you.
Thank you so much for joining me.
Thank you. Thank you so much for having me. I hope that we could do more of this as well because it's a way for me to even learn, review, remember. Yeah.
Sure. Thank you. Thank you so much for watching this video.